2026. Looking forward to a very exciting year and hopefully a very informative year. And as you will see, there is a whole goal and intended purpose for these discussions so that we can discuss objective evidence and you feel what is that well-informed informed consent as far as decision such that if someone is interested in getting implants, you know what you're signing up for, what is exactly your surgeon should be discussing with you. If you want to get an explant, what exactly should your plastic surgeon be discussing with you. It is extremely important for you to do your homework and to do your research and your analysis so that as you make your decision, you feel very content and well informed about and well educated about how your surgeon does it. So in my practice, which is exclusively devoted to removal of saline implants, silicone implants, and residual capsules, you will see the Khan procedure, which is what I do. I want you to go ahead and join my Facebook group page, which is the breast implant illness support group page by Dr. Khan. And you please go ahead and join the YouTube page, Executive Plastic Surgery or Khan Plastic Surgery Academy. And please join so you can go under live, YouTube Shorts, and YouTube videos so you can see exactly what is the role and basically essence and gist of my practice. And as you will see, every surgeon, plastic surgeon who does an explant will do it their own way, their own style, their own systematic method. It is literally what I would call on-the-job training for the plastic surgeons who are doing end blocks or 100% total capsulectomy or their own formula as far as what they have deduced and deducted over their career. Every surgeon has their own way, and in my way is basically where you will have the Khan procedure where the implants are returned to the patient 100% of the time. Number two, capsules are always sent to pathology to rule out that rare BIALCL, which is the breast implant associated anaplastic large cell lymphoma, and rule out breast cancer, rule out any breast abnormality. Cultures are done for bacteria and fungus, aerobic, anaerobic, and fungal. Number four, twilight deep sedation, where anesthesia gives propofol, fentanyl, Versed. The patients are not paralyzed, and a general anesthesia is given via the ventilator. Number five, the drains are not utilized. I have not used drains in any of my patients in well over 6 years, even with the many 800 cc ruptured implants, many implants with extensive inflammation, simply because all the bad tissue is removed. No need for that unnecessary lift. You will see I do that Khan pseudo lift where I cut out the excess skin at the bottom. And between the recoil of the skin, the gravitational pull of the implant that's pulling the breast tissue down, between that concavity effect of the implant sitting on the rib, and now the rib is going to expand out, between the 5, 10, 15% muscle mass the patient will add to their chest post-explant when they exercise, when I tell them and how I direct them, and between the recoil of the skin and the breast tissue, and between the inflammation subsiding, most of my patients, 80% of which do not need that unnecessary lift. Number 7, you have the high definition pictures and videos of the chest wall showing complete removal of the capsule and the implant. If you ask me, this is extremely important. How can you verbally and visually and systematically guarantee that the whole capsule was removed? Your surgeon takes the high definition pictures and videos of two things. Number one, the chest wall showing complete removal of the capsule plus the implant plus all inflamed tissue. And in my practice, that means removal of the fascia of the intercostal muscle, removal of the fascia of the pectoralis minor, removal of the fascia of the serratus anterior, intercostal muscle fascia, the periosteum, perichondrium, and that is the direct visual evidence that all of that badness was removed in its entirety. And that also the second set of videos are the cutting open of the implant capsule on the table consistently from one patient to the next. And number 8, no matter what the comorbidities of the patients all get the same surgery. So in the year 2025, I operated on someone as young as 25 to as old as 89, and the patients in the age group, despite their comorbidities, they got their surgeries done in exactly the same manner using what is that Khan procedure. I want you to please chat GPT the Khan procedure. I want you to chat GPT the Khan Dakai pseudolift. That really overall adds that aesthetics to the chest breast area. Now, another question that I get asked a lot, is it safe for me to travel? I will tell you, over in 2025 kind of year in review, I've had patients from India that came from Europe, from South America, from literally every state of the United States, from Canada, from Mexico, and patients have traveled from far away. I believe earlier in the year in 2025, I had a patient that traveled from New Zealand, and that was by far the longest that any one of my patients has traveled. She took a flight from, I believe, Auckland all the way to Houston nonstop, and then from Houston to Detroit. And so this is where my patients come to me from far away. Almost 80% of my patients travel to see me. As you will see, a lot of progress was made in 2025, where we opened up a second location in Northridge, California, and we will be heading there next month in February, 8 and 9. And then in April, the tentative dates are going to be 8, 9, 10, 3 operative days in April, which we're going to announce tomorrow. And so that truly has been very popular. I just learned if I could have 1 month of surgery in California, I'd probably fill up in its entirety. That's how busy we are in California. And hopefully we'll have another exciting third location announcement later on in the next few months. And so that is kind of in the works. Truly a lot of patients that we helped in 2025. So this was a very nice, productive year. A lot of patients with a lot of ruptured implants. And if anyone has been following on the Facebook Lives and the YouTube Live, you can see and join us, so that almost every Facebook Live, there is something to learn, even for myself as I dissect and I operate on the many patients that come to me from far away. The other thing I want to mention is, one of the questions I got asked was the DVT prophylaxis, which means deep vein thrombus. Between everyone getting the heparin subQ shot, everyone out of bed to cheer on the day of the surgery and the following day up and about and gently walking, between the twilight deep sedation where the patients are not paralyzed, where the muscle paralysis does not occur, the patient's blood does not pool in the legs, and the chances of getting the clot are certainly very diminished, minimal to none. You will see that patients get the compression socks that they wear on the morning of the surgery, and when they have arrived at their final destination, usually on that Friday, Saturday, they can then take that compression sock off, and everyone gets what is the SCD boots, the sequential compression devices inside the operating room. And as you will see, the patients overall do extremely well. The one thing I want to mention here is I started off my consultations over after the first New Year. The one patient I talked to was a patient from overseas who actually had an explant done, but did not have the entire capsule removed, and the surgeon attempted to remove the capsule through the nipple areola complex. As you will see, if you follow me on Facebook, on YouTube, you will see that is virtually impossible. The capsule spread is certainly very much so you cannot dissect directly perpendicularly through the nipple areola straight down and through a small hole. The diameter of the implant essentially dictates the length of the incision, so that is very much key. And in order to get the proper adequate exposure, you have to make a cut that is approximately the diameter of the implant. And remember, when the implants were placed, they were 2 finger breadths below the clavicle, and now the implants have only moved downward and outward. So the dissection down at the bottom of the breast allows for adequate exposure to dissect all the way up into the upper chest And this is an incision that's going to hide right in the crease. And this is an incision that allows me to do what is that Kandakai pseudo lift. And this is extremely important because you have to have that adequate exposure. One of the plastic surgeons reached out to me, a local, and he said, I'm trying to do what you're trying to show me. And his incision was roughly this big and the implant was twice the size. How can you use such a small incision and dissect all the way into the upper chest? And it is extremely important to basically have good visualization so that you're not running into bleeding, you're seeing the whole capsule, and that the dissection is done in a very pristine manner. Remember, this whole surgery is all about respect, which means that there is complete 100% integrity, professionalism, sincerity, religious dissection, wholehearted, honest dissection, such that the entire capsule is removed. And as you can imagine, Mar, if you can give me a glove, if you can imagine that if my fingers are the ribs and majority of the implants are sitting below the muscle right on top, and this is the implant, for example, it is stuck, the implant is stuck super glued literally to the ribs. And so in order for me as a surgeon to remove the entirety of the implant, plus the capsule, the fascia, which is the layer directly on top of the rib, has to be removed, which is the cartilage part of the rib, the bone part of the rib, that layer that's directly on top, which is the perichondrium, periosteum, the fascia of the muscle that's directly in between the rib that has to be physically removed, that fascia, the fascia of the pectoralis minor, the fascia of the serratus anterior, which is the muscle on the side of the chest, such that this blue layer is essentially also removed. And as you can see, I'm going to go ahead and try to peel this off, such that all of this tissue, the capsular tissue, is removed, such that there is no capsular burden remaining behind, because we don't want that ruptured implant to spill into the chest. And that is essentially the gist and heart of what is explant surgery. Today, I saw the pathology report on one of my patients where the patient had fat necrosis that I removed that was dead fat, silica particles. This is basically the proof in the pudding, if you will, where what is removed is sent to pathology. So I've seen dead fat, histiocytic reaction, multinucleate giant cell reaction. This is the inflammation cells that are present within that capsular tissue. All the badness removed, such that when we look back at any of my cases in 2025, 2024, 23, 22, 21, and all the years in the past, there is complete, sincere dedication into removal of the whole capsule and the implant in what is that en bloc fashion, or 100% total capsulectomy, such that there is no inflammatory burden left behind. And this is the essential gist and heart of what is explant surgery. One of the plastic surgeons from France was asking, you remove the whole capsule? And I said, you bet. Ask any of my patients my patients received the high definition pictures and videos. They have clear cut 1080 videos, high definition videos of their chest wall showing complete removal of the capsule and the implant and all inflamed tissue with no bad tissue remaining behind. And that is the ultimate and the only proof that your surgeon did the explant in the en bloc fashion. So this one patient who already had her explant has spilled silicone, because that silicone spilled into the chest from 2019 ruptured implant. And the surgeon attempted to remove that ruptured silicone through the nipple areola complex incision. You can only imagine how much of it spilled and tracked along the way through the breast tissue. This is not how explant surgery is done. There is a certain etiquette and finesse, and the high definition pictures and videos ultimately prove that entire implant capsule was removed in this systematic, thoughtful approach. So this one patient who had implants from 2019, ruptured implant that were intended to be removed via en bloc fashion through the nipple areola complex, she's going to be getting an MRI of her breast in order to show if there's any residual silicone inside her chest breast area and capsule, and so that I can define the pockets where this ruptured silicone is hiding. And this is where it is a much more difficult, involved operation because the patient did not get the right surgery to begin with. So this is the take-home message from the early part of 2025. Do it once, do it correctly, do it definitively, do it with absolute certainty, do it as your last operation. You do not want to be coming back or finding another surgeon who will remove the residual capsules or the spilled silicone, because that is what I have said many times before, the worst case scenario. Now, the other thing that I've been asked from the consults that I did over the break, how come your pictures are not as good as the other surgeon's pictures? I looked at another surgeon's pictures that the patient brought forth, and it turns out these are 10 pristine pictures, maybe even AI generated. And these are pictures that are the ultimate ideal, probably not even of explant patients. And this is wrong information. If someone has a ruptured implant, capsular contracture, or history of radiation to the chest breast area, or multiple surgeries like 6-8 surgeries, you will never get the same results 100% of the time in these patients. And so this is an illusion that the surgeon is portraying on his or her website. And this is by far not the final result, meaning this is a selective, basically finding of those 10 best pictures and portraying that this is, you're going to be the 11th picture. So when I made my website, there was mock pictures and model pictures that the website manufacturer want to share and say we will post these as before and after, and we will have in a very nice fine print clause that, oh, these are representative, these are model pictures. This is wrong. You have to be very direct and open. Most of the pictures, for example, I have are 3 week, 6 week. You want to be looking at pictures that are a year and a half out. So in my practice, I refuse to use the model pictures. One patient actually was so smart, she saw another surgeon's post-op results and another surgeon in California, the same picture, because they were interchanging and sharing the model pictures. And this is where you cannot trick the patient into finding or choosing the best results that the surgeon is putting forth. So you have to be very careful as a patient to be not falling into the trap. You have to ask the relevant questions. There are so many factors that come into play as to what the final outcome is going to be. Was the surgeon board certified? How many surgeries did the patient have? Some patients have had 2, 3, 4 sets of augmentations. Was the implant above the muscle, below? Was there capsular contracture? Did the patient have an infection, seroma, or other problems? And certainly a malpositioning, double bubble deformity, other problems that the patients may have as a result of their initial intervention. So it is extremely important for you to be very smart about processing information. So in my practice, I never touch the breast tissue, which means I never make a cut around the nipple areola up and down, or basically a lollipop incision, or a S lift or a J lift, because 80% of my patients, as mentioned earlier, do well without that unnecessary full lift. And if this is the muscle, for example, if this is the muscle and this is the nipple areola, this is the breast tissue, this is the muscle, the breast tissue is below the muscle in P2 and the breast tissue is above in P1. Again, this is the nipple areola, this is the breast tissue, this is the muscle. The P1 area is where the breast tissue is. P2 is below the muscle, which is where the implant is. And these are the ribs. So I'm always in the P2 section, always in this section below the muscle. I never touch the breast tissue above, and that's why I can operate on patients who are actively nursing. So I always stay below the muscle, and I remove the entire implant capsule. In a normal patient, there is no extra volume that I remove other than excess skin problem, and that is that pseudo lift. And I always stay below the muscle. So number one, I never touch the breast tissue. And number two, I measure the distance from the nipple down to the crease. If it's 6.3 centimeters on the right and the left side is 6.7, I will cut that extra difference such that it will also be 6.3 centimeters from the nipple down to the crease on the left and also on the right, and such that without touching the breast tissue and by measuring with the ruler inside the operating room, I'm going to make sure that both the right and left sides are going to be balanced out. Again, the most important thing for you to do is to follow the surgeon. Now, every surgeon needs to be transparent, as transparent can get. As you will see, I have my Facebook page where I have over 16,000 followers. Anyone can DM my other previous patient and talk to them directly, openly, freely. They have that will. This is a very healthy, open environment in that private setting, in that private breast implant wellness support group page. Or if you go join my public Shaher Khan public support group page, where we can all discuss in a very healthy way, such that you can learn more about my practice. And my practice is as transparent can get. And I encourage my patients to share their results, their experiences with the many patients, so that you have that peace of mind and confidence that you sign up as a patient. You can certainly be extremely confident and excited about the surgery that you're going to be getting. So please go join my Facebook group page and the YouTube page so you can learn more about me. You want to be happy mentally from processing this information from your heart, from your gut, such that when you do make a decision, you will know this is absolutely the right decision to make. This past weekend, over Saturday and Sunday, I had the privilege to talk to a patient in Germany. I had the privilege of talking to a patient in Kuwait, in the Middle East, which is close to Dubai. I have had the privilege to talk to patients from California, from Florida, from Alabama, from the Connecticut, and this is where, please seek out the free complimentary phone consultations. Again, there is no obligation on your end. Continue to listen, to follow what I have to say, share this message and journey with the many others. I want to go ahead and highlight 3 things. If you go to my private breast implant wellness support group page and even the public one, you will see questions to ask your plastic surgeon. Those are very important questions, and that kind of is pretty much, I would say, what is the comprehensive list of questions to ask your plastic surgeon. The other thing I want you to do is I want you to go to this and Google this information: breast implants, certain labeling recommendations to improve patient communication, guidance for industry and Food and Drug Administration staff, FDA, issued September 29, 2020. And here you will have everything you possibly need to know about implants from the FDA, not from me. And so introduction, background, scope, labeling, components, boxed warning. So let's go to this page 4, and you will see the boxed warning that is listed right here. Boxed warning: breast implants are not considered lifetime devices. So that means if 100,000 patients get implants in their 20s, 100,000 of them will eventually need a replacement, plus minus 10 years. Because remember, the longer you have them, the higher the chances are you're going to have problems, because that is the exact next line. The longer people have them, the greater the chances are that they will develop complications, some of which will require more surgery. So they're not lifetime devices, as many of my patients have walked in saying that this is what their plastic surgeon had told them. Now, the second line: breast implants have been associated with the development of a cancer of the immune system called breast implant associated anaplastic large cell lymphoma, BIALCL. So in my practice, I demand the pathologist do a CD30 analysis, so we basically know with confidence that there is none of that BILCL. So this cancer, quote, this cancer occurs more commonly in patients with textured breast implants than smooth implants, although rates are not well defined. So the smooth implants are also implicated in BILCL to a lesser extent. Quote, some patients have died from BILCL. Now, the third line is very interesting. Patients receiving breast implants have reported a variety of systemic symptoms such as joint pain, muscle aches, confusion, chronic fatigue, autoimmune diseases, and others. Here they're telling you breast implant illness exists. There should be ICD-10 code for it. Hopefully in 2026, there is legislation that's going to be passed that will push for this ICD-10 code so the patients do not have to pay out of pocket. So this does exist. We know it. We know it because the implants were banned in 1992 to 2007. Next Quote, individual patient risk for developing these symptoms has not been well established. Some patients report complete resolution of symptoms when the implants are removed without replacement. So they're telling you if you have BII and you remove them completely, that you will have that relief. And if you will see the next page, you will see all what are the detrimental effects of getting implants. And I'm just going to read them out to you. Page 11. Risk of breast implant surgery, breast pain, skin or nipple areola sensitivity changes, asymmetry, impact of aging or weight change, infection requiring possible removal of implants, swelling, scarring, fluid collections, hematoma, tissue death of breast skin or nipple, inability to breastfeed, complications of anesthesia, bleeding, chronic pain, damage to surrounding tissue such as muscle, nerves, blood vessels. Now, if you look at the impact on imaging of breast tissue may occur, then it talks about the lymphoma. So you saw those risks. I'm going to go ahead and read some more. On page 14, now remember, these are not my words. These are words of the FDA. I understand that the long-term risks of breast implants may include painful or tightening of the scar tissue. That's the capsular contracture, rupture or leaking of the implant, wrinkling of the implant, visibility of the implant, shifting of the implant, need for reoperation. If you look over here, top line, quote, top of page 14, I understand that silicone can migrate from my implant into nearby tissues, chest wall, lymph nodes under the arm, and organs, liver, lungs, where it may not be possible to remove. That's a big deal. I understand that all breast implants can interfere with mammography and breast exams, which could delay the diagnosis of breast cancer. That alone should be a reason to not getting implants. Mammography can also cause the breast implant to rupture or leak. The next thing, I understand that all breast implants contain chemicals and heavy metals. I understand that most of these chemicals stay inside the shell of the implant, but small quantities have been found to diffuse gel bleed through the implant shell of silicone gel fill implants, even if the implant is intact and not ruptured or leaking. A list of the components of chemicals and heavy metals is available in the patient information booklet brochure. And remember, they want you to initialize patient initials. All of this is patient initials. And then if you look at the quote, bottom of page 18, heavy metals found in breast implants, arsenic, barium, beryllium, cadmium, chromium, cobalt, copper, lead, magnesium, mercury, nickel, platinum, selenium, silver, tin, titanium, vanadium, zinc. I will tell you the risks of the implant are certainly very much real, very much there is no denying the fact. No one comes into my clinic and says my implants are making me healthier, think better, I have more energy, I have my eye vision is improved, I can think sharper, clearer. If anything, is only bad. Anyone and everyone who walks into my clinic from the complaints of migraines, arrhythmias, difficulty breathing, thyroid problems, hair loss, dryness of the eyes, ringing in the ears, dryness of the mouth, throat trickling, chest pain, the neck, back, fibromyalgia type issues, tingling, numbness in the arms and legs, slow muscle recovery after muscle activity, GI issues, rheumatological joint problems, which are the hallmark feature. Why, if I'm a patient and I'm interested in getting implants, all what I have read, not my words, I did not write this, I would run as far as possible from the implants as fast as I could, as far away as I could. And this is the do no harm oath that I took. And the goal here is do no harm to your body. It's not worth the pain and misery and the effort. And remember, you will eventually end up paying the price. And it is, remember what I said earlier, if 100,000 patients get implants in their 20s, they will not be living with them forever. There will come a time, 7, 10, 15 years, that they will need to get them replaced, hopefully removed permanently and in the nice manner. And there is a certain etiquette and a certain standard and thoughtfulness into this. So in my practice, if I look back at all the cases that I did in 2025, I cannot imagine a single case where I would go back and do the case any differently or any better because I gave it the best shot. Every patient gets booked for 4 hours for the operating room time so that they get 110%. I have had patients wait 3.5 hours for their surgery because that's how long it took for me to finish the case earlier in the morning, for example. That was my second case. And if the patient has a lot of comorbidities, I have gone to the hospital in order to do those cases because the patients would not meet criteria in an outpatient surgical setting, and still was outpatient surgery for those patients as well. Now, what we're going to do is a series of Facebook Lives, primarily on Mondays, YouTube, TikTok, Instagram. Feel free to ask any questions, and I'll be more than happy to address them and answer them. We will look at the manufacturer's advertisement. So if you look at this, this is a nice advertisement from Mentor, and you can see the moderate high profile, the Mentor Memory Gel Boost breast implant portfolio brings another dimension to complete, Mentor Memory Gel Boost breast implant options. Connect with a local representative. Here the advertise. Then you will see that black box warning. And then if you read the fine print, it says, for example, quote, MRI screenings are recommended 3 years after initial implant surgery and then every 2 years after to detect silent rupture, close quotes. No one talks about this because this is very real. And if you look at this booklet by the FDA, let's go ahead and go to the section on imaging. You will see all of this highlighted. Page 14 by FDA, even if I have no symptoms, I should have my first ultrasound or MRI at year 5-6 after my initial implant surgery, and then every 2 to 3 years thereafter. If I have symptoms or uncertain ultrasound results for breast implant rupture at any time, an MRI is recommended. So the test of choice is an MRI without contrast, no radiation, no contrast, to look for what is a rupture. And the rupture can be intracapsular or extracapsular. And this is where the radiologist has to read carefully so that we know the positioning of the implant. We know where is the rupture. If it's an extracapsular rupture, exactly where does it go to? Now, if you have any of the questions, feel free to ask, and maybe a couple questions.
Yes. So one question from Instagram, do you go through insurance?
So this is an excellent question. Now, the biggest, and I will say, there's a lot of, the insurance says, if I were to get implants, insurance is going to say, who told you to get implants? And when you remove the implants, even, for example, if you have a rupture or a capsular contracture, and those are usually one of the two criteria where they will go ahead and compensate you. Now, you have to go look at your own insurance rules. They will say to you, who told you to remove the capsule, because no one believes in that. And they say, they will try to push this on you and say, who told you to get implants? So if you get implants, the burden's on you. Any surgeon who takes insurance to remove implants is not going to do the complete surgery, because the 4 hours time that I take, and if I were to take insurance, I would be filing for Chapter 11 by the end of this week. So let me say this again. Any surgeon who takes insurance will never do the correct surgery, because they will never spend the 4 hours from their heart and soul and mind in order to doing the surgery that will only reimburse them $750, maximum $1,200 plus minus. And so this is where you have to be very careful not to fall into the trap. Oh, my surgeon takes insurance, so I'm going to go ahead and opt for him, and he's going to do a good job. Now, remember, in my practice, I know 5 criteria that your surgeon is a genuine good surgeon, and that he or she meets criteria to doing the right surgery. Number 1, the length of time of the surgery is approximately 4 hours. Having done thousands of these, start to finish, some are sooner, some are longer, but on average, plus minus 4 hours. So if your surgeon is booking you for surgery for 90 minutes, I will tell you with 100% reassuredness that you will not be getting the right surgery. Number 2, the length of the incision should be approximately the diameter of the implant. You saw the case earlier I mentioned where the surgeon went through the nipple areola. You cannot do an end block or 100% total capsulectomy from the nipple areola. So you have to have an incision that's going to be roughly the diameter of the implant. So the 4-hour surgery plus minus, longer is better. 4 hours is how long it takes for me start to finish to doing a case from start to finish. The length of the incision is approximately the diameter of the implant, and an incision that's going to hide right in the crease. Number 3, your surgeon is a firm believer in breast implant illness to the point where he's actively talking about it. He is talking about breast implant illness. He recognizes breast implant illness. One of my other patients went to another surgeon who did not want to even utter the word breast implant illness. How can he even do a surgery if he does not believe in breast implant illness? And he still augments. So that is also a big red flag. If your surgeon is putting in implants, he does not believe in breast implant illness, because you cannot believe that the earth is round and flat at the same time. Either you have to say the implants are bad or good. You cannot have it both ways. And this is a political statement. Many surgeons want to capture both. In a time of where we are financially, like in a recession, many surgeons are saying, of course, if it takes for me to say BII is real and I get the patient, that is not good enough. You have to be not augmenting. You have to have a very open Facebook page where you're actively discussing how you're doing the explant, and and that the surgeon is a firm believer. And on their website, they have breast implant illness. You have the breast implant illness technique, how they're doing it, and why they're doing it, and they're not augmenting. And within the same practice, in the same roof, you cannot have another surgeon who's augmenting, because one of my other surgeons, he basically called out to me and he said to me, in my practice, I have myself, that others, he himself is only explanting. He said, I can market myself better by saying that, and my other colleague is augmenting nonstop. And so if a patient calls augmentation, they go to that other surgeon. If they want explant, they come to me. And this is extremely unfortunate, ethically, and unprofessional. So the surgeon should actively be explanting only, and the entire group practice must be explanting only. They should not be augmenting, and they should be actively talking about their approach. They should be excited about it. You shouldn't have to twist that arm and force them to say, okay, please do it. Because remember, it's all about integrity and honesty. You should actually go to your surgeon and say, I want a replacement. And if they say, sure, let me sign you up, automatically you should run away. One of my patients came to me and said, I did skin cancer on her and she wanted to get a replacement. And she said, I will pay whatever you want. I said, absolutely, I will never do a replacement. I will only do a removal. And I told her, go find yourself another surgeon. And in a replacement is a very easy, simple operation. And the bottom line here is your surgeon should only be explanting and be very open and excited and very, genuine and sincere about basically talking about how and why he does it. He should be energized intrinsically, not showing off and saying that he is an explant doctor. By the way, there is no list of surgeons. This is all a bogus garbage list that exists out there. Who's the board of American explant surgeons? It's people who have no surgical ability, no medical training, no background. These guys are, basically nail salon experts, if you will, and they're now making the call about who's the expert explant surgeon versus who's not. This is 100% misinformation, wrong information, and sometimes financially driven information. So you have to be very careful. One of my patients told me, oh, you're on the top 10 list. I will tell you that top 10 list was generated by another no-name surgeon who put the names of 3, 5, 7, 10, 9 other explant surgeons, and who squeezed his name in there in order to make himself more legit. And that is a garbage, bogus, self-made list by these surgeons in order to enhance their narrative that they want to be part of this group. Remember, this is earned by the patients, who have gone through, who validate and authenticate. If you ask me, a lot of explants done in 2025 were not good in my mind and my sight because of what I see, what the other patients report to me. Number 4, again, the most important thing is your surgeon is returning the implants to you. If they're saline implants, they were not punctured. The silicone implants too, they were not damaged on the way out, and it was done in the en bloc fashion. And so that is important. Number 5, your surgeon must, and by far the single most important thing, provide high definition pictures and videos of the chest wall showing complete removal of the capsule plus the implant plus the fascia of the intercostal muscle, fascia of the serratus, fascia of the pec minor, and the fascia of the pericardium, periosteum, because that is the ultimate proof. No one can deny the fact that the capsule was not removed in its entirety, and the fact that the drains were not used in itself is a proof that there was no badness remaining behind. And this is the sixth, the drain. I did a Facebook Live with a nice doc from the Netherlands 3 months ago. And God bless her, she was very nice and honest. She said that when she goes in and dissects below the muscle, she gets as much of the implant capsule out, and there are some areas in the upper part of the chest where she's not able to remove the entire capsule. And then she just cauterizes it, washes it out, and puts a drain in, calling it a day, which is, in my practice, a big no-no. And this is what, unfortunately, what I find a lot of surgeons are doing. Your surgeon, again, must provide the high definition pictures and videos, and the surgeon should and must not be using drains, because that in itself is proof that the surgery was done in the manner as described. And remember, this surgery is all about integrity, honesty, and sincerity. So the most important thing you can do, again, is to join the YouTube page, Con Plastic Surgery Academy. Go to my webpage, executiveplasticsurgeon.com. There on the landing page, you will be invited to join the private breast implant illness support group page or the public one. Follow along with me as I will do the hundreds of Facebook Lives, YouTube Lives this year as I did in 2025, so that you will see what exactly my practice is about. It's very transparent. There is only one intent and purpose, which is to help the quality of life of the patient. There is utmost sincerity and devotion into patient care, well-being, safety. There is value of the patient's experiences. I will tell you, I'm blessed to have the best staff, the best team, the best OR team, the best anesthesia team, so that any patient who has come our way has had the best experience. And also in California, we did a total of 7 surgeries in the month of November, and I am blessed to say all 11 of the patients are doing extremely well. We look forward to a lot of surgeries in California in 2026. Any other questions?
Yes. Would you ever do a pro bono case?
I will tell you, unfortunately, 80% of my patients that have come to me, they would have benefited from some sort of a financial assistance in the world that we live in, and we know it is hard. And I will tell you, for me, I just want to mention there is no disclosure on my end. I have no financial commitment to any supplement group or team that they're trying to sell products, which they have approached me many times. I have been approached by many Instagram and Facebook owners who have 10, 20, 30, 100,000 patients, and they wanted to basically me to pay them, and they would flood me with patients, and I said no to that. They wanted to write off of my patients so I could promote them, and they would honor me by basically they would advertise for me. I said no to that. There were many what I would call groups that reached out to me so that they could take advantage of and I did not even give them 1 cent, 1 quarter, 1 dime. My commitment is to the patients, to their health and their well-being, and there is no other intended purpose for my practice. I just want to mention that there is no disclosure on my end, and I want to mention, hopefully the federal government will step up and basically reimburse the many patients who are literally hurting. They are in a state of misery. Many patients with rupture implants who do not have the financials to basically getting the explant. There are many patients, unfortunately, who use their insurance, end up going to local plastic surgeons who state that something is better than nothing to get the implant removed, at least because they know they will never be able to afford a full explant. I've been told by many patients in 25, 24, and 2023 that I do not charge enough. I'm not exaggerating. For the time and effort that I spend with the patients myself before, during, and after, with the time that I spend with each one of my patients. I've been told by many patients again that I do not charge enough. Remember, this surgery is all about professionalism and integrity. From the time it takes for me to finish the case, 4 hours, I could easily be done with 3 augmentations, and I would have gotten amount pretty much more or less the same for each one of the augmentations that I get charged for the explant. So 3 augmentations I could have done in the time it takes for me to do 1 explant. And remember, this is where it's not only finances, but it's the physical stress, the mental stress of the surgery, the physical ability to dissect with the head down and neck in a very tedious, meticulous fashion, which, this surgery certainly is. It is not an easy surgery. And if you ask me, one of my friends, my colleagues, he said, I'm interested in learning how you do the surgery so that I can reproduce it with my patients, his prospective patients. And he said he does not want to do it because it takes too long. It requires a lot of concentration, dedication, and it requires a lot of meticulous dissection. And he said he did not like the invasiveness of the surgery and the amount of time. And he said he would rather do 3 augmentations or 2 augmentations than the time that he would have done that explant. And this is essentially goes into showing you that it has to be done from the heart, mind, and soul with pure professionalism and integrity, and this is not an easy surgery. So going back to answering your question, anyone who takes your insurance will absolutely not be doing the right surgery. And going back to the point, I wish, for me, in order to arrange for a team to get everything certified, if this is the standard that we have, if we look at the surgical experience, the OR, the equipment, the staff that I have to pay, believe it or not, at the end of the day, it's not a lot of money. One of my friends, he is an orthodontist, and he said he was telling me and laughing at me and saying that he does not charge but a few $1,000s less for his patients when he puts braces on. And he was telling me that since I do such a complex surgery, given the expenses and the OR and all of that, certifications that I have for each one of my staff members, plus the credentialing and whatnot else, he said, I am surprised you do not charge more. And this goes on to showing you it's not about it's all about the whole overall commitment from start to finish, such that you get the best surgery possible, the best experience possible for what is a very involved and invasive surgery. But this is a surgery that certainly needs to be done in the manner described, so that as you get the surgery, just like all my patients in 2025, I couldn't be happier with each one of them. I would not have done the surgery any differently, knowing what I know about each one of the patients that I operate on in 2025.
Another question, what are the chances of getting breast implant on this if I get silicone implants?
So this is a good question. There are many patients. My very last patient from today, she had the questionnaire empty and she said, I have no symptoms. And there are many patients like that. There are patients that have come my way and they had 0 symptoms. Now, lo and behold, this one patient from Ann Arbor, Michigan came and saw me, and I asked her, why do you want your implants removed? And she said, well, my 10-year mark is up, and she had no symptoms on her breast implant on this questionnaire list. And believe it or not, as I went in, her right breast implant was ruptured. Now, you would think she would have known, she would have had pain, some discomfort. No, this is what they call a silent rupture. Again, if I may, mentor advertisement, the lower part, as you will see, MRI screenings are recommended 3 years after initial implant surgery and then every 2 years after to detect silent rupture. Silent rupture means I do the exam, or even 1,000 plastic surgeons do an exam. They will look at this patient from Ann Arbor and no one will be able to tell, not a single one of the 1,000, if this patient has a ruptured implant or not. Ultimately, even the MRI has been proven wrong. We saw many cases in 2025 where the MRI said to this nice 31-year-old patient that came from Virginia that both her implants were ruptured. And so she came to me and she said, go ahead and do the en bloc. I did the en bloc. We did the Facebook Live, and lo and behold, the MRI was dead wrong. Both the implants were intact. And conversely, there was a patient where the MRI said intact implant, I did this case at the hospital, and lo and behold, it turns out that the right implant was ruptured along with the left. And this goes into showing you the MRI is not 100% positive, meaning there's false positives and false negatives. So the bottom line here is there are patients who have no breast implant symptoms, but remember there are other problems that I read that occur. You could have capsular contracture, you could have inflammation, acute and chronic pain. This is an very interesting evil disease in the sense that the patients love this implants. So there are many patients I have managed, for example, who had implants through the 90s. They actually signed waivers when Dow Corning sent them checks and they said, go ahead and get your implants removed and we'll reimburse you, we'll pay you, we'll cover you. And they signed waivers that were responsible, we would like the implants. And lo and behold, everything was fine, and then all of a sudden the symptoms started going haywire, and then now the patients started having problems. And this is where you, as a patient who has implants, who is considering implants, you may have this quote nice honeymoon period, maybe 5 years, maybe 10 years. And then all of a sudden, plus minus, the longer you have them, the higher the chance you're going to have problems. Now, there are many patients that I've seen, they said that this was the best thing that this was the best thing that ever happened to them. They really enjoyed the implants. This was an excellent investment. Then all of a sudden, the pain comes, the capsular contracture, the arrhythmia comes, the anxiety, the panic attacks, the hair loss, migraines, neck, back, shoulder problems. Some patients got diagnosed with RA. Now, we do not know there is a direct association, but they tell you in the black box warning, patients receiving breast implants have reported a variety of systemic symptoms such as joint pain, muscle aches, confusion, chronic fatigue, autoimmune diseases, and others. Individual patient risk for developing these symptoms has not been well established. Some patients report complete resolution. Complete resolution means cure of symptoms when the implants are removed without replacement. So the point I'm trying to make here is you may have an excellent period, then all of a sudden your time will come, maybe 10 years, maybe 15 years, maybe 20 years, maybe 25 years, but your time will come. And on average, if you ask a good reputable board certified plastic surgeon, the 10-year mark plus minus is the mark. Before or after, I have a patient that I am going to be operating on in the next couple of weeks. Her symptoms, she has an implants. So today I saw a 24-year-old patient, just today. She had her complaints in 2 years. So she has implants exactly for 2 years and 1 day, and now she wants to get an explant in the next month. This is an example of a patient I just saw in clinic today. There are patients that I've taken care of. 2 decades later, they presented, and this was my last patient today. She has implants from 18 years ago, saline implants, and she says she is the one who said she has no symptoms of BI and she wants them out because she cannot exercise. She's an instructor and she is unhappy the way they are sagging, bottoming out, and how she has what are neck back problems. And she said maybe it's her age of 58 and neck back joint problems. Is it postmenopause? Is it the tired feeling that she has because it's cold and it's depression right here in this cold Michigan weather? And she checked off no boxes. The point I'm trying to make here is there will come a time sooner or later you will run into problems. So I was talking to another plastic surgeon who said, well, breast implants are lifetime devices. I said, absolutely not. It says here, breast implants are not considered lifetime devices. The longer people have them, the greater the chances are that they will develop complications, some of which will require more surgery. Plus minus 10 years, you will see. Look, the rate of rupture goes up after the 10-year mark significantly. So if you look at any of the studies that have been done to look for silicone breast implant rupture, you will see they all stop at 10, 12, 13 years because they know the rupture goes up significantly higher and they do not want to have studies showing that the rupture rate goes up. And the bottom line here is they are not lifetime devices and they're only associated with problems. Now, if someone gets implants, we do not know what the course is going to be. Maybe you're going to be wanting them out in 2 years. Maybe you're going to be wanting them out in 20 years. Maybe you have a silent rupture that you're sitting on for 5 years. We do not know. And this is where you have to do your due diligence. This one patient I talked to from 2019, she just had them in for 6 years, and she's telling me she has a ruptured implant, and she wants this out. And this is the patient that I talked to from overseas. The bottom line is you never know what your course is going to be, but the course is ultimately going to be only bad because they're not lifetime devices. And this is where you as a patient have to make that informed decision, informed consent, that you're signing up for a device that you will eventually need to get replaced, hopefully removed permanently. And if you do get removed, you have to get it removed in that thoughtful, nice, systematic way.
No more questions
Okay.
so far.
Yep. So again, a warm welcome to everyone, the new members. Please share your journey. If you are part of a group, share your discussions with another member and say, please come and let's join and let's listen to this doctor. Your surgeon must be very devoted, committed into helping you. You should be talking to the surgeon directly, not to the medical assistant, not to the nurse practitioner, not to the physician assistant, not to the front desk person, not to anyone else, but to the surgeon directly, because he or she is going to be doing the surgery. Your faith and your commitment and bonds is on that legal document that must state 100% total capsulectomy or unblocked fashion. Implants will be returned, high definition pictures. Spell it out on the consent form that you're going to get all of that back. If you don't get your pictures back, chances are you did not get the right surgery. Again, all those criteria that I mentioned, and you want to have that peace of mind. So my patients, when they put their head on the pillow and they get their surgery done on a given day, they have that peace of mind, number one, that all of that bad tissue was removed, implant capsule, all inflamed tissue, and all of it was tested. And this is that smile, that peace of mind, that tranquility. This one patient that came today from Kentucky, her husband is a surgeon, and they both back and forth went through question answers. They came from far away and they had done their homework and they had a smile on their face because they know what they're signing up for. And this is essentially what the whole goal and just. So I will end with this on my end. If you want to get implants, please know what you're signing up for. And this is part of the informed consent. And if you want to get an explant, please know who you are signing up with so you know what you're getting, what you're signing up for, so that you have that peace of mind and confidence that your surgeon is a firm believer. You have that confidence and the belief that your surgeon is going to do the right surgery, and you're never going to be second guessing your surgeon because he or she met all the criteria that I talked about. Share your knowledge, share your information. Initially, you might be overwhelmed by the answers, questions, but if you follow along, it's that same recurrent theme. End block or 100% total capsulectomy, high definition pictures and videos, complete devotion and commitment to excellence and nothing but that, safety, accountability, and reliability, and that best experience that hopefully we will deliver to all of our patients that we operate on and discuss and share the knowledge with in 2026 and the many more years to come. This is Dr. Khan, Executive Plastic Surgery.